emulsification cataract surgery.
Hi, good evening, everyone. You can hear me well at the back there, can you? And is everyone okay there? If you are having the lessons online? Hello? Yes? I suppose so. So Vivian will be helping me with the lectures and maybe answer some of your questions if you have any questions online there. Anyway, so today's lecture is going to be divided into two parts. Part one is called Common Eye Problems, and the second part is on the actual planning of the community needs. If you can recall from your first lecture, you have come across information or anatomy of the eye and ocular structures. Is that correct? So hopefully you can recall some of the information that you have gone through in your first lecture, because those information will be closely related what we are going to talk about today. So the topic that we are going to talk about is common eye problems, but not just any form of common eye problems, but those problems that have a more severe consequences that may lead to visual impairments or even blindness. So let's have a look at what are the common eye problems that can lead to visual impairments or blindness, and that include cataracts, glaucoma, age-related macular degeneration, and diabetic retinopathy. So I believe some of you may be from a non-health faculty background, so these may be quite new to you. So hopefully by the end of this lecture, these names or these eye diseases will become, you'll be more familiar with these names and eye diseases. And in today's lecture, apart from those that we just mentioned, we are also going to talk about retinal detachment and dry eyes. And these two points, point 5 and 6, these two eye diseases are also very common in our population. But fortunately, they may not necessarily lead to any severe consequences, and especially with dry eyes. However, these conditions may still be very disabling in our daily life in severe cases. So, so we will also touch on that. So if you can recall from your first lecture on ocular structure, hopefully you will remember the crystalline lens. Have you seen this picture before from your first lecture? I suppose so. Crystalline lens is a structure, it's a transparent structure that positioned behind the iris. And the main purpose or the functions of it is to allow light to get through. And very importantly, it's also help focusing the light or the images that comes with the light to focus on the retina, that is the back of the eye. So this has a very strong focusing power. What happened with cataract is this supposedly to be a transparent structure becomes opaque. So when it becomes opaque, like the second picture on your right, what happened is, of course, it will obstruct or reduce light from getting into the eye. And therefore, as the severity of cataract increases, the visions will also decrease. So this is a nicer picture, more like a photo. Left-hand side, this is a clear lens structure. So you can see a light through it. You can see that it is quite clear, and the light rays can actually go through the lens. And of course, because of the space at the back there, you can't see the structure at the back very well. Whereas the structure on the right, you can see that the center of the lens becomes quite milky. And with this structure, you can imagine not a lot of light can get through. And so with the patients with this eye structure like this, the visions will become quite poor. And as on this slide, it tells us that cataract is actually the first leading cause of blindness in the United States, and it's very common. I'm sure you have heard of the, if not the English name, the Chinese name, right, of this eye disease. What happened with this is the crystalline lens is made of protein. So as we age, as this protein denature, and that's why it becomes opaque. So that is more like a natural aging process. And as we look at these different photos, we can see that there are actually different types of cataract. You can see that it can be, this is a normal, the resolution is not very well, but this is supposed to be a normal clear crystalline lens. Whereas those on your right, you can see that the cataract can be of different shapes and can be in different parts of the eye. And you can also think about if the cataract is more at the center, or imagine the pictures that we have just seen, that it is all in the center. Of course, this type of cataract will be more disabling. It affect vision much more than those cataract at the side, right? These happens with the denaturing of the protein at the fibers at the side. So if you are unfortunate enough to have cataract, but fortunate on the other hand that you have this type of cataract, it will not affect your vision until in a later stage where the cataract sort of encroach and come into the center part. Okay, so even if a patient has cataract, it doesn't mean that the visions will drop dramatically or right away. It really depends on where the cataract is. And the bottom right-hand corner, this shows you how mature cataract will look like. So we can see that pretty much like a whole crystalline lens becomes opaque and very limited amount of light can get through. And you can imagine the visions will be quite poor in this case. Okay. Who is at risk for cataract? Well, as we just mentioned, aging is one big factor. So aging of the lens structure leads to this denaturing of the protein in the crystalline lens. And so age is one big factor. The older you get, the greater chance that you will have in developing cataracts. So we usually have elderly patients that test cataract, but that is not there are, of course, exception cases like congenital. That means you are born with cataract, but fortunately, it is quite rare. And other risk factors include patients with diabetes, that is, patients with these metabolic conditions that can lead to the development of cataract. And history of trauma is also one risk factor, and also steroid use. Therefore, you have to be very careful with use of steroid. In the past, you may have heard of stories that people, supposedly you need to have a prescription for steroids, but if you get it illegally, kind of, and then continue and long-term use and unsupervised use of steroid can lead to cataract. And also one big factor in having or developing cataract is UV radiation. So protein may also change in relate to UV exposure. One thing to take note of, or you may notice, is third world countries, people living in high altitude, they may develop cataract at a younger age. Okay. What are the symptoms of cataracts? Well, the most common complaints from patients will be blurry vision. And also they may experience increased light sensitivity or glare problems. So as you can see here, these complaints are quite non-specific. Patients with a change in their prescription may also complain about blurry vision, etc. So you really have to look into the lens and to see if that is a contributing factor to that drop of vision. And also one important point to note is that their eyes will not have any signs, so they will not feel red or pain, or they don't feel pain or any swelling. So on the outside, their eyes look fine, but their vision is actually dropping. So this is a simulation of how the cataract may look like. And there, so as you can see here, the drop of vision and also the contrast is reduced. Contrast meaning that it's not as black and white, and then these things becomes all like fogging up. So how are cataracts detected? As we just mentioned, that the main complaints will be blurry vision. So we want to know how blurry is the vision. So visual acuity test is one important information that we want to see. Also that it is important for us and also for the patients to take note of how their vision is being affected by cataract, and so that we kind of know what is the conditions that the visual conditions that is, and that will be an important information for us to give advice or recommend whether they are in the positions or to undergo cataract surgery. And as mentioned just now, visual acuity test is more like a subjective test. It's a subjective test, so it's patient telling you how well they can see, etc. But for a more objective test, it is important for us to look into the slit lamp. You all understand what a slit lamp is, right? You should have learned about this in, I think, your first or second lecture. It is a special equipment like this that allows us to look inside the lens that give rise to the pictures just now. The anterior part of these pictures were taken with a slit lamp. So you have the light that goes through, and you can go through the lens and see. This is a camera with a slit lamp. So that's how the slit lamp is done. Slit lamp examination is done. So we can actually see through the lens and see if there's any cataract, any opacity in the crystalline lens. And how can cataracts be treated? Well, cataract surgery is the only option because once the protein denatured or the lens becomes opaque, there's no medications or other ways to turn it back into clear. So in that sense, what needs to be done is to remove the cataract lens and put in a man-made implant. We call it an intraocular lens. So that will give clear visions to the patients. So cataract extractions and implanting a man-made intraocular lens is the only option. But fortunately, in the early stage, as mentioned just now, especially it depends really on where the cataract is. It may not affect vision too much, and the patient may not be bothered by it too much. There can be cases where The slit lamp shows that there is cataract in some parts of the lens, while the patients actually do not feel about the drop in vision, and so they don't have any symptoms yet. So that is also possible. But once it progresses to a point where it affects the patient's daily activities, then surgery is needed. So nowadays, the recommendation is that when it interferes with daily life, then one should have cataract surgery done. In the past, people used to think that you need to wait until the cataracts are very mature. So if it is not in a mature stage, then you are not supposed to have the cataract surgery. But that is a wrong conception, pretty much related to the limited resources of the government hospital, trying to postpone cataract surgery because the queue waiting for cataract surgery is long. So that is one reason that that's given to the patient, saying, oh, your eyes are still good because the cataract is not mature enough. So let's wait until it's mature enough to have the cataract done, the surgery done. So, but nowadays we have a more subsidized program for cataract surgery, and also in general, people are more well off, so they can go for private doctors and have it done much earlier than wait for it to become mature. Okay. And yeah, so this is the same slides as before, where it's, on the right side is supposed to a cataractic lens and then implanting into a man-made one. So let's have a look in the video and see how it is done. These pictures are more old-fashioned, where you have a big incisions in cutting open the eye and putting a big lens in. But nowadays we have microsurgery, so everything is done nicely, and you need a very small opening or small incisions in the eye. So let's take a look at that.
A cataract is the clouding of the eye's natural lens, a structure which is positioned behind the cornea, iris, and pupil. Like the glass lens of a camera, our lens adjusts to focus our vision. The lens is mostly made up of water and protein. As we age, these proteins change and may begin to clump together, obscuring portions of the lens. To correct this, a doctor may recommend phacoemulsification cataract surgery. Before the procedure, the surgeon numbs the area with anesthesia. Pressure may also be applied to decrease the internal pressure within the eye. This will lower the chances of complications later in the surgery. Then a small incision is made in the cornea of the eye. Fluids are injected into this incision to support the surrounding structures. The top of the lens capsule is then removed to gain access to the cataract. The surgeon then uses ultrasonic waves to fragment and emulsify the clouded portions of the lens. They are then removed. Once the cataract is removed, an intraocular lens, or IOL, will be placed into the empty lens capsule. Small struts will hold it in place. Once properly positioned, the synthetic IOL restores the patient's vision.
Okay, so that is quite clear on how the cataract surgery is done. Okay, and yeah, as mentioned, so now it is the incisions and everything is much smaller and nicer because of the availability of these surgery and special equipment. Okay, so how can we prevent cataracts? Well, we can look back at the risk of cataracts. There is things that we can done with UV protection, minimize exposure to UV radiations by wearing sunglasses with appropriate UV protection, and wear wide brimmed hats to protect your eyes from overhead sunlight. Uh, because there are, especially with so much high rise in Hong Kong, UV radiations can actually reflect it from concrete or glass or etc. So wearing wide brim hats is important as well. And when we look at how to prevent cataracts compared with who is at risk for cataract, well, we can't avoid aging, so that's something that we can't do anything about. It is also related to diabetes, so keeping your general health healthy, that can also help. And steroid use will lead to cataract, so of course no exploitation on the use of steroid is also one point. Okay. And also smoking is bad in all sorts of health, not just eye health, but in general health. So quit smoking is also one point that can prevent cataract. And the intake of vegetables and fruits, because these contains lots of vitamins and antioxidants, and that is good for the eyes. So these are things that we can take into considerations, and that can help with not just cataract, but many other forms of eye disease. Okay, is there any questions so far? If all is good, then we move on to the next topic, glaucoma. This may sound more unfamiliar to you compared to cataract, but this is actually the second leading cause of blindness in United States and the first leading cause of blindness in Hong Kong. The scary part of glaucoma is that it is what we call the silent thief of sight. And you will learn about why it's got this name by the end of this topic here. Let's have a look at the structures of the eye. If you remember, hopefully you can recall what you have learned from your first lecture again. This is the anterior part of the eye. So just now we talked about the crystalline lens. But if we flipped it and enlarge the picture looking at this, we have two important structures that relate to this eye disease, glaucoma. The structure here that is just next to the crystalline lens, it is responsible for producing the fluids in the eye. And these fluids will flow through from the side of the lens and flow out through the angle. This angle is between the iris and the cornea, and the fluids will flow out. So imagine the eye has what at the back we call vitreous, more like a jelly thing. And the anterior part is filled with fluid called the aqueous humor. So it's pretty much the eye structure, and the eye inside is like with fluid filled. And with these producing fluid or aqueous humor and then outflowing, these have to be kept in an equilibrium, more or less like keeping the eye pressure inside constant or in a healthy range, right? So if anything goes wrong, for example, the structure here producing too much, or if the outflow is slowed down or even blocked, then there will be a building up of eye pressure inside the eye. And with that, that's causing damage of the optic nerve. And where is the optic nerve? it is at the back here, but this is a very delicate structure because it is responsible for sending messengers of what we see to the brain. So these are delicate nerve cells. With anything damaged here, we actually cannot send information to the brain, so we cannot sort of interpret what we are seeing. Okay, and that's no use, even if the other parts of the eye structures are all intact and healthy. So this is an important sort of like messenger of sending information to the brain. Okay, so glaucoma, it's a special situation where the eye pressure is not in equilibrium and is not balanced, and that's why there is damage in the optic nerve. This is like a simpler terms of explaining glaucoma, but in real life, people can still have glaucoma if they have normal eye pressure. But to understand the mechanism, it's a very complicated mechanism behind. So to keep things simple, let's just think about an increase in eye pressure pressing against and making the optic nerve at the back there unhealthy. Okay, I think that is the important concept to grasp. And we just mentioned that it is the first leading cause of blindness in Hong Kong, and the percentage is pretty much 3% for everyone over the age of 40, so it's actually quite common. And then again, who are at risk for the development of glaucoma? Well, family history is one big thing. So if the parents or siblings, etc., have glaucoma, they are at a greater risk. And also age is another thing, because probably as you get older, your optic nerve becomes less healthy, and any change in the pressure can cause more damage to the optic nerve. So anyone greater at 45 years old are considered at a greater risk. And again, use of steroids. We've just talked about unsupervised use of steroids may lead to cataract, and here it may also lead to an increase in eye pressure, and then as a result leads to glaucoma. Patients with high myopia. So this may relate to any one of us who have short-sightedness of greater than 6 diopters. And that is also one reason why myopia control becomes such a hot topic nowadays, because high myopia or high amount of short-sightedness is also closely related to a lot of eye diseases as well. Okay. So what are the symptoms of glaucoma? Well, when we talk about glaucoma as a silent thief of sight, it's more related to what we call open-angle glaucoma. Remember, we have just mentioned that glaucoma is caused by an increase in eye pressure, and with that, the mechanism may be an increase in the structure that produce more fluid, or there is obstruction or blocking off of this angle, that is an outflow of the fluid. So open angle, that means the angle is okay, the outflow is pretty much okay, but more related to the production of fluid or the aqueous. And that's why it builds the eye pressure in the eye, it is built up slowly. And it doesn't go rocket high. It may be slightly elevated, or that patient may even have normal, as mentioned, normal eye pressure. So the patient, him or herself, won't feel a thing, but we know that with glaucoma is that the eye pressure is not in equilibrium with other pressure in the brain, and so the optic nerve the nerve cells are dying, and there are damage in the optic nerve, and in the end, there will be functional loss. Functional loss, that means the functions of the eye is reduced. And with that, the symptoms is actually restrictions of the visual field, or as it's mentioned here, losing the side vision. So with our vision, we have our central vision that is responsible for very fine detailed things like looking at the screen, looking at me, reading, etc. But we also need our side vision to move around, right? And then also to detect things coming from the side. So with glaucoma, you have very good central vision, which is not affected by it at all, but you have a slowly reduction in the side vision. So what happens is, because we usually don't take note of our side vision as much, right? We may notice a drop of central vision very easily, or we're more alert when that is being affected, because like if you can see the things clearly now, but if one day you can't see it, you will notice it immediately. Whereas your side vision, if it is slowly restricting the side visions, you may not notice until at a very late stage, where you may start to bump into things and not noticing people waving at you from the side, things like that, or car coming in from the side. And that may already be quite severe in terms of the disease, in the stage of the disease. So as you can see here, you can have a full view of this picture, or the side vision is slowly disappearing until you have what we call a tunnel vision. That is more like you have a clear central vision but losing the side. So that's why the name a silent thief of sight comes with glaucoma. Okay, so that is just the first part. That is the open angle type of glaucoma. On the other hand, there is a second type of glaucoma, which is called closed angle, because it's just the different from the open angle. One is open angle, the other one is closed angle. And remember what the angle is for. It's for outflow of the fluid. If it is closed off, because this angle is more like a sewage system, right? What happens if it is closed off? It's like flooding, right? You have quickly building up of the eye pressure inside the eye. And in this case, this type of glaucoma, your eye pressure goes rocket high. So it will go really high. And that's why for this type of patients, you will notice really there are a lot of symptoms. As explained here, you have blurry vision, because when the pressure is really high, your cornea becomes unhealthy and it's losing its transparency. It's like fogging up. So you have blurry vision. And because the pressure is building up, you can really feel the eye pressure in the eye, and you have headaches and malaise, like nauseation, or you feel like vomiting, and also redness of the eye. The blood vessels also enlarged. And this is an ocular emergency, because if it is not treated right away, you can result in total blindness, because then your optic nerve in such critical conditions, because of the eye pressure is so high, and you have to treat it right away. Okay, so this type is called closed angle glaucoma, or acute. Sometimes it's called acute closed angle glaucoma, etc. All right, so there are two types, open angle or closed angle. For the open angle, is asymptomatic. Patients probably don't notice it very much, especially in the beginning. And when they eventually notice there is a drop in their side vision, usually that's in quite a late stage, and it's quite late to have that treated. And the other is acute closed angle glaucoma, and there are these very noticeable symptoms experienced by the patient. So how is glaucoma detected? Well, we mentioned How the disease come into place is because of an elevation of eye pressure. So of course you have to measure their eye pressure, see if that's within the normal range. And another very importantly is to examine the optic nerve head to look at it, see if it is healthy. And to be more precise, there are ways now with special equipment to measure this optic nerve head. This is a picture of a optic nerve head at the bottom right-hand corner. And this is a glaucomatous nerve head because this nerve fiber is really thin. That means they are dying, they are unhealthy. So there are specific equipment to measure how thick is the nerve fiber layer. If it is thinner than normal, then there may be early signs of glaucoma. And last but not least, in the later stage, the patients will experience a drop in their sight vision. So that's also one way to see how the conditions, in which stage of the condition is. In the early stage, they may not show any drop in the peripheral vision or side vision. So that's also, we do what we call a visual field to test how far they can see from the side compared to their age norm. So that's why annual eye examination is important, because this type of condition is very easily go unnoticed if they don't have a proper eye check. Okay. And how is it treated? Well, there is no full cure for glaucoma, meaning that once the damage is done, you cannot reverse it. So let's say if the patient has got drop or losing a part of the side vision, we can't have anything, eye drops or surgery or anything to reverse this damaged, okay? And the treatment kind of is like keeping the condition as it is. So hopefully there is no progression of the eye disease. So it is the aim is to prevent any further damage to the optic nerve. And to do so, we have two ways. One is eye drops, medications, topical medications. The eye drops is for controlling the structure and reducing the fluid that it produces. So it will produce less fluid, so reducing the eye pressure. And also, it can be done by surgery. That's putting a hole on the iris, to put it in simpler terms, that is increasing the outflow. So if we think about the mechanism of how it occurs, how glaucoma occurs, the treatment is basically reducing the production of fluid or increasing the outflow. Okay, and as mentioned, once the damage is done, we can't reverse it. We can only keep it as it is to prevent further damage. So timely examination is important. So if we delay treatment, delay detection, that means delay treatment, and maybe more damage is done. And so, as it mentioned here, the best prevention is through early detection and early intervention. Okay. Right. So we have finished our second topic on glaucoma. Is there any questions? Okay, so let's move on to our third topic on common eye disease is age-related macular degeneration. So the name is pretty self-explaining. So it is age-related. So usually when it's age-related, it's related to old age or older age. And macular, do we all know what macular is? At least we know it is a structure in the eye, is on the retina, and it is responsible for central vision. And so this disease is a degeneration related to the macular, and it happens in the older population. Okay, so is pretty self-explaining. Okay, so if you remember this picture, I'm sure you have come across this before, right? So this is a retina. This is just part of the retina, but more like a central part of the retina. This is the optic nerve head, to be more precise. So just now when we talk about glaucoma, and when we look into the optic nerve head, see if it is healthy, we are looking in this and see if the nerve fiber thickness is thick enough, or if it shows any sign of thinning. That's from here. And now we are looking at this structure, which is called the macula. And as mentioned just now, it is responsible for central vision. And this is this area here. And why it looks at this is a special structure compared to other part of the retina, because if we look at it sideways, this is the area there, and inside this is a special structure called fovea, which is the central part of the macula. Well, basically, this is responsible for central vision, and as we can see here, the macula has a high density of cone photoreceptor for central vision. And the fovea, which is the center part, which is even more important because this is the center of the macula, point with highest density of cones. So this is already with a high density compared with the side. But inside there is this one point with the highest density of cone and for the highest resolution of image. So that's why if we look at things with our central vision, we can see it much clearly compared with our visions from the side, right? We can see motions and movement from the side, but it is not clear from the side. We need our central vision to see color, to see fine detailed things. And that's all I want to talk about here for the macula. Yes, that's pretty much it. Okay, so that is a very important structure in the eye, because if anything that happens with the macula, our central visions will be affected, and that will be very disabling. Imagine you can't see things clearly. You may need to, when you read, you may need a magnifying glass. When you look at TV, you need a telescope. And so that will be affecting your daily life much more than the conditions of a glaucoma, for example, if it's still in the early stage. Okay. And so that is what happened. This is just a picture, a simulation. Kind of if there is degeneration in the macula, it may look like this. So this becomes patchy and it's not nice compared with the nice picture there, which is a normal macula. And how can we test for ARMD? Well, all these tests basically test for the functions of the macula. And the first thing first will be visual acuity, because we mentioned it affects our central vision. And of course, how do we test our central vision? Is through our VS. So our normal VS test will tell us whether that patient has got normal visions, normal central visions or not, on conditions that you are giving the proper prescription. And contrast sensitivity, well, same as cataract. So the contrast sensitivity of the patients may be reduced. And here we have a more nicer picture to show you what contrast sensitivity is. So if you look at this chart on the right-hand side, you will notice that this is very different from our normal Snellen VA chart. Our Snellen chart, we have the letters arranged from big to small, and we're testing how fine we can see. So it goes to the smallest line and see if you can see the fine detail where you can actually identify the small letters. Whereas the contrast sensitivity chart has these letters all of the same size. From the first row to the bottom row, you probably can't see much at the bottom here, but with different resolutions or a different colored monitor, you probably see differently. But anyway, this chart is supposed to go all the way down, so you have a more reduced contrast. And as you can see here, these are of the same size, but they are reducing in the darkness, in the blackness of the letters. From the first few are quite black, whereas as you go across and then down the chart, you can see this contrast, black on white, is reduced. So that is also one way of testing your macular function, see if there is any reduction in the contrast sensitivity. Of course, for healthy eyes, you should be able to see some of the really low contrast letters. But if your contrast sensitivity function is reduced, you may not be able to see these low contrast letters, and you have to really see black and white. And I also like you to think about what, if you have a drop in contrast sensitivity, what it affects in daily life. Actually, it can be quite disabling because in real life, we don't usually have, for example, things on our Snellen chart like always black and white. In real life, we have much more things that are of lower contrast. Just like imagine walking on stairs. The edge of the steps may look like similar color to the next steps. That's why if you can see that design for visually impaired people, they have the edge of stairs taped with really bright color, so to alert them that is the edge of the steps and things like that. So contrast sensitivity actually have a very disabling effect if you have if that function is being affected. And we mentioned macular is responsible for color vision, so color vision test, that's also one way of testing the functions of macular. And central field test, we will talk more about that in our next slide, especially with the Amsler chart, which is a special test that we test for the health of macula. And electroretinogram or ERG, this is not as common in performing that, usually maybe in hospitals or in a research setting. So not really commercially kind of available. And other tests, but we're not getting into too much detail of that. So let's have a look of the Amsler chart. So we are looking at the central 20-degree field, pretty much like here. We're testing the functions of the this part of the retina. And the dimensions of the Amsler chart is 10 centimeter times 10 centimeter, and we're doing it at 20 or 30 centimeter. And the patients have to do it monocularly, that is covering one eye and just looking at it with one eye. And the patient is supposed to look at the center. As you can see here, this is the chart, this is a standard chart. And if you look at the center, white dot, center white dot, and the patients have to have their eyes fixed on the center dot, and then feel about how the lines of the grid chart, whether there's any wavy lines, any change, anything missing. Just like our next slides. If there's any metamorphopsia, any change in the shapes, or the lines are supposed to be straight, do they become wavy, do they change shapes, or if there's anything missing. So if missing, we call that scotoma, but there are two types called absolute scotoma, that is absolutely nothing, you can't see anything there, or is it just a relative scotoma, that means you can't see that as well compared to the other parts. If you can still see the lines, but the lines are just not as clear, we call this a relative scotoma. Okay, but with the absolute, there's really no lines at all. You can't see anything there. Okay, so these are some common complaints if there's any really problems with the macular, and it shows in the Amsler chart. And who is at risk? And again, then as the name suggests, age is one big factor, and it is more likely to occur for people after 60 years of age. And smoking is also one thing. Family history is also one thing, same as glaucoma. And intake, some research suggested that intake of fast food or fatty diet is also a risk of ARMD. So basically keeping, again, same as the other eye diseases, keeping a healthy lifestyle can help reduce the risk of all these types of eye diseases. And the symptoms, well, in the beginning of the disease, there again are no symptoms in the early stage. When there's no structural change that you can see, you may not notice anything. And then the visual acuity may be just slightly reduced, but because we have two eyes, we may not notice it if it just happened in one eye. So as the disease progresses, your visions will drop more rapidly, and then the patients will notice it eventually when the visions becomes poor. And this is like in a very severe case, as you can see, a lot of bleeding. There's a lot of degenerations of the macular area. And actually in the end, because of all these bleeding and then new blood vessels form, there will be scarring. And if the lesions in the macula is supposed to be photosensitive cells, right? What happens if it becomes a scar tissue? That means all these photosensitive cells are gone, okay? And without these photosensitive cells, that means we can't see things, right? So with this scarring, we will have a loss of central vision. That means we can still see the side, but the central part is gone, and you really need to use the side vision. If it happens in two eyes, then the central vision will be very poor, and you need to use really a big magnifying glass to see things, because you are using, imagine you're using your side vision to read. That would be quite difficult. Okay, so that is what happened in the late stage of these patients. And how is ARMD treated? Well, in the early stage, as mentioned, keeping a healthy lifestyle. So quit smoking, protect from UV also, and nowadays people also recommend these dosage. So in the beginning, maybe vegetables, fruits, and as it becomes more severe as the disease progresses, there is actually a study that tests about these antioxidants or vitamins and minerals. What dosage can actually help slow down the progression? So it is a study called ARES-2, and so there are vitamins, especially for the eye, especially for macular degeneration. And so that would be recommended for the patients to take these special dosage vitamins for slowing down the progression. And in the advanced stage, as we remember from the last slides, there may be bleeding and then new blood vessels formation. That is a big no in the eye disease. Injections of special medications can help stop the formation or the formation of new blood vessels. And we just mentioned, how do we prevent keeping a lifestyle modification, healthy lifestyle? So before the need of antioxidants, before the needs of the ARES-2 medications, it's good to actually increase the intake of antioxidants, which is healthy for the eyes in the first place. And then also a healthy lifestyle, exercise, water, UV protection, no smoking, etc. Injection. Okay, I thought I have a slide, a video on injections, maybe in a later slide. Okay. we'll talk more on injection in the eye, because the injections in the eye is also one of the treatment for the fourth topic. Anyway, so is there any questions so far for age-related macular degeneration? If all good, then we move on to our fourth topic, diabetic or hypertensive retinopathy. Why we're putting these two together is because their mechanisms behind are quite similar. But of course, diabetes or conditions of the disease of the retina relating to diabetes are much more common compared to hypertension, but we'll talk about each of these. So what is diabetes mellitus? It is a group of metabolic diseases, high blood sugar level, right? It's causing damage to the blood vessels in the body. So of course, our eyes, our retina have got lots of capillaries. And of course, our eyes will be affected if with these diseases, if it affecting the blood vessels in the whole body. And there are two types of diabetes. Type 1, it happens in the younger generation, and it is more like an autoimmune disease. And it is when the pancreas cannot produce insulin to control blood sugar level. So it's an autoimmune disease. It's pretty much like a destruction of the insulin producing cells in the pancreas. So it happens in juvenile diabetes. Whereas type 2 is when the cells in the body that do not respond to the insulin, even if its amount is enough. So the pancreas is producing enough insulin, but the body cells are not reacting to that. And it's also called, that's why it's also called insulin resistance type of diabetes. And it is much more common in the society. It accounts for 90% of the total diabetic case, and it's also related to obesity. So if you are leading a very unhealthy life and you're at a risk of developing this type 2 diabetes. Okay. And this is a projection of what may happen in the year 2030. But before we look into the graph on the right, let's look at the one on the left. This is a global prevalence of diabetes mellitus. As you can see here, this x-axis is of years or age. And so as you can see here, the older you get, or also the increase in the prevalence of diabetes mellitus. So as you get older, the greater the chance of becoming diabetic. And with this unhealthy lifestyle of modern people, it is projecting that in the year 2030, you will have a big increase in the population with diabetes, especially in the middle age group. So keeping a healthy lifestyle is important. That will reduce the chance of diabetes, and that in turn reduce the chance of developing diabetic retinopathy. Because if you don't have diabetes, you will never get diabetic retinopathy, right? And so what is it? What is diabetic retinopathy? Well, we mentioned because diabetes is a metabolic disease that affects all the capillaries, arterioles, venules in the body. And our retina is full of these, right? Full of the arterioles, capillaries, and venules. So it may be affected by diabetes. And what happens in these blood vessels when you have diabetic retinopathy is when the blood vessels become unhealthy, there may be hemorrhages, so like bleeding from the blood vessels, or you can have, because of the hemorrhages or the leakage from the blood vessels, you have swelling, you have retinal swelling or edema. Edema means swelling, or exudates. These are also leak leaking from the blood vessels. And the worst is with all this bleeding and leaking and all that, you are encouraging new blood vessels because the old one is not healthy. Let's grow some new one. Okay, and with that, that causes a lot of problems because of scar formation and all that that comes with the new blood vessels growth. Okay, so this is how it happens. And of course, diabetic retinopathy also have a big range from maybe 1 or 2 dots of hemorrhages to scar tissue. So it ranges from a very mild case or just the beginning of abnormal blood vessels to the end stage, which is new blood vessels growth and all sort of unwanted consequences. And now we jump to hypertension because this is of a kind of a similar metabolism there. That is also because of how the blood vessels is not healthy and is causing retinopathy because of unhealthy blood vessels. So we understand that hypertension, that means high blood pressure, and it means abnormal high blood pressure. For adults, this is kind of a normal range, and the hypertensive range is anything greater than 140 in the systolic pressure and greater than 90 in diastolic pressure. And for children and teenagers, you have a slightly different range. To be more precise, you can actually have these range for different ages. To be more precise, if you're in to compare, which is within your age norm. Okay, but in general, as mentioned, if you're above 140 and the diastolic is above 90. And again, because with modern unhealthy lifestyle, you have a greater prevalence of people having high blood pressure. So it becomes a growing public health concern as well. And then in the same way as diabetes resulting in diabetic retinopathy, high blood pressure, it also affects the vessels in the eye, and that's why it may also lead to hypertensive retinopathy. And also there is one possibility. If you see recurrent, this is called subconjunctival hemorrhage. That is the blood vessels on your conjunctiva, the white part of your eye. If you have constant hemorrhaging of these recurrent hemorrhaging, and if you are in the older age group, then you better encourage the patients to have their blood pressure measured, because that is also one sign. But of course, if you're young and if your blood pressure is within normal range, you can still have that because it can be caused by mechanical rubbing or mechanical force, so rupturing the blood vessels on the conjunctiva. But if nothing happens, no rubbing, and it's just the blood vessels just pop on the conjunctiva and nothing really happens and it's recurring, then you better have a body check or your blood vessels check. And yeah, so this can be a sign if you are in the older age group and it occurs frequently. And this is a retinal photo that shows you, so you have a similar signs like the diabetic retinopathy. You have hemorrhage. So this again is due to unhealthy blood vessels leaking, so bleeding, kind of papillodematous swelling of the optic nerve head. And so these also exudates from the blood vessels, so it's leaking white thing or dying of the cells because of lack of oxygen, because of unhealthy blood vessels. So all sort of funny things are going on the retina. And okay, so who is at risk of diabetic retinopathy? As mentioned, all patients with diabetes. So one way of reducing the chance of diabetic retinopathy is to reduce the development of diabetes. And also, if the patient has it for a long time, he or she is at a greater risk of developing diabetic retinopathy. So uncontrolled diabetes and the duration of having diabetes are also risk factors, and also coexisting of diabetes and high blood pressure is also one risk factor, because that means both factors is contributing to unhealthy blood vessels in the eye. And who is at risk of hypertensive retinopathy? Well, same as diabetes, so anyone who has hypertension, high blood pressure, and also for those uncontrolled high blood pressure, and also for those who had it for a long time, and also for those who have diabetes as well as hypertension. Okay, so these are the few factors that putting a person at greater risk of developing these two conditions. And what are the symptoms? Well, again, in early stage, if there's only one or few dots of hemorrhage, a little bit of leakage, it doesn't affect the central vision, no swelling of the retina yet, so there may be no symptoms and no pain. The findings may be good vision, everything is fine, but if we look into the retina, there may be start to have the change in blood vessels, so we may be seeing leakage, this exudates, or bleeding or hemorrhages and things like that. And in a late stage, if the macula is involved, the patients may experience blurry vision. Like if the macula becomes swollen, then the patients may experience blurry vision. Or if it affects other things, you may have like this. We just mentioned about absolute scotoma, like this. So parts of the things in the vision is gone. And how is retinopathy detected? The main thing is by looking into the retina. So it is by examining retinal examination or fundus examination. The word fundus can be used interchangeably with retina. So that means retinal examination, using this special equipment or taking photos of the retina. Okay, and how is diabetic or hypertension retinopathy treated? Well, it is caused by unhealthy blood vessels, right? So one way is using this laser to sort of seal off this unhealthy blood vessels or stop any new blood vessels growth. Of course, but in doing so, you will also affect the side vision. But at least you are preserving further damage to the retina. And nowadays, more positive results or the treatment options is moving towards injections, because this is a special medicine that is for controlling the swelling of the macula and also stopping the growth of blood vessels. And yeah, I want to show you this. This may look a little bit scary, but then it just shows you it is quite a simple procedure in injecting into the eye.
First, we place the lid speculum to hold the eyelid open, and I'll ask you to look up, like you're trying to look behind your head. Perfect. Use a drop of providone iodine in the location of the injection. I like to measure where I'm placing the injection. You might feel a slight pressure, usually no pain. Use a cotton tip as the needle is withdrawn. How do you feel?
Fine.
Excellent.
Yeah, so as mentioned, it may look scary, but it is actually quite a simple procedure in it. And
lid speculum.
In this video, we are using a SOS basic phaco eye.
Sorry. Let's close it. Okay, yeah, so as mentioned, I just want to show you that this is, although scary, but it looks scary, but then it is effective and also quite, yeah, it's quite an effective treatment for the condition there. Okay, so how is this condition prevented? Well, as mentioned many times already, that maintain a healthy lifestyle, so exercise, no smoking, maintain a balanced diet, and then regular eye and health check, weight control, all these helps preventing the development of diabetes and hypertension. Okay, and we have finished on the main topics of the common eye disease. But then we still have two smaller topics to talk about. One is on retinal detachment, because this is also a common eye disease. And also it relates to a lot of Hong Kong people, because as I can see, a lot of you wear glasses. And because high myopia is a epidemic problem in Hong Kong or in Asia. And people with high myopia is having a greater chance of developing retinal detachment. So I also want you to learn more about this as well. So as the name is, the retina is detached. And some people may mix it up with floaters and flashes, which are actually symptoms that may occur before retinal detachment happens. But for floaters, on its own, it may be just a metabolic change in the eye. It may not necessarily symptoms of retinal detachment. But what happens is with the vitreous in the eye, when you get older or if your short-sightedness is increased, the vitreous basically shrinks or becomes more liquefied. And with that, it pulls on the retina and causing a hole in there, and fluids get behind it, and you have a detached retina. Again, family history, patient with family history or at an older age is at a greater risk, because as mentioned, the vitreous may shrink in the older generation. So as the vitreous shrink and pulls on the retina, there is a chance of causing holes or tears in the retina and causing retinal detachment. And also, history of eye trauma, cataract surgery, and other eye diseases may also increase the risk of retinal detachment. And yeah, we just mentioned about why it concerns more for Hong Kong people compared with Caucasians, because we more of the population have a higher amount of short-sightedness. So patients with high myopia is at a greater risk for developing retinal detachment. The symptoms, well, early stage, no symptoms, but as mentioned, you may experience flashes of light or floaters. In the later stage, watery visions, you can imagine if the retina actually gets detached and there are fluids behind, it is not flat or nice anymore. It may float around a little bit, and that's why it gives you watery vision. And if it's detached from the back, that means you can't pass on what you see to the brain, and you have part of the vision blocked. Some clients may, or some patients may explain that it's like a curtain blocking off the vision, blocking off part of the vision. And if it is not treated early, you have a permanent damage to the retina, and you have a permanent vision loss. And this is also why yearly examinations are important, because then if you have the pupils dilated, have a thorough look at the peripheral retina, then you will see if that patient is at a risk of having holes or tears at the side. Maybe you have degeneration at the side and things like that. So any signs that you may advise on the patients and things like that. So yearly eye examinations. And with retinal detachment, it is a medical emergency. Laser surgery or other treatment ways is to stick the retina layer back onto the retina. And just show you quickly, it shows you how the development of retinal detachment happens and how it is fixed.
In this video, I'm going to demonstrate why we see floaters and how retinal tears and retinal detachments are formed. Floaters are black specks in the field of vision. To understand floaters, we have to know about the vitreous gel, which occupies the vitreous cavity. Over the years, the vitreous liquefies and little pockets of fluid form within the gel. This process is called vitreous syneresis. As syneresis continues, eventually the fluid will escape between the vitreous gel and the retina, causing the vitreous to separate from the retina. This is called posterior vitreous detachment, or PVD. PVD is an acute event and is a common cause of floaters as the fibers of the vitreous become more visible. A posterior vitreous detachment is usually uneventful. However, occasionally the vitreous gel can cause traction on the retina if it is adherent in a particular spot. If the traction is strong enough, it may cause a retinal tear. This is why a retinal examination is necessary when one experiences new onset of floaters. A retinal tear is treated with laser, which is applied to the area surrounding the tear to prevent passage of fluid under the retina. If a retinal tear is not treated, eventually fluid will pass under the retina and create a retinal detachment. A retinal detachment causes a black shadow in the field of vision. Surgical treatment is required to repair a retinal detachment.
Okay, so that's pretty clear of how make it happen, how it happens. Yeah. Okay. And so that concludes our topic on retinal detachment. Again, is there any question? No questions, then we move on to
The comprehensive dilated eye exam, opening the door to preventing blindness. During a comprehensive dilated eye exam, the patient receives special eye drops that dilate the pupils.
Okay. Yeah, back onto the last topic on dry eye. Excuse me. Yeah, so when we talk about dry eye, we have to understand the mechanism of tear layers. And when we talk about layers, usually you only think about water. But in fact, tear layers consist of 3 different types of materials, different types of component. That includes oil, water, and mucus. And each of this is important in the formation of tear layers. The mucus actually is the layer that is closest to the eye. Without the mucus layer, imagine the eye drops on a glass bowl. What happens is you will have water droplets, and it won't give you a clear layer of water. So the mucus actually help to spread the layer of water evenly on your cornea. Without it, your eye is not actually water liking, so the water droplets will not spread so evenly because water layer in the middle is such a thin layer, so it needs the help of the mucus to spread evenly on the cornea and the conjunctiva. And then, of course, the water layer in the middle that's helped to wet the eye. And the outer layer is an oil layer of oil, and that helps to prevent the evaporation of the water in the middle. If you have any imbalance in these three layers, it can result in dry eye. Imagine if you have insufficient oil, and that may increase the water evaporation, and it results in dry eye. And of course, if you have a reduced production of the water layer, of course, you have dry eye. And too much mucus will also cause problem too, right? It makes your eyes really, or too much oil secretion will also cause problems. Your eyes becomes really sticky and uncomfortable, and it may even obscure your vision. So you have to have these three components in good equilibrium with each other in order to have a healthy, comfortable vision. And so what is dry eye? Well, it occurs when the eye is not producing enough tears. So when we, as mentioned, the tears include the three components, mucus, water, and oil. And when the tear composition is not consistent. So tears evaporate too quickly, as mentioned, if the oil layer is not properly produced. Or sometimes dry eye is triggered by an unfavorable environmental factors like the use of aircon or very dry places in the desert, things like that. Or if your environment or the demand of long-term use on the computer that reduce your blinking rate, that can also cause dry eye. So who is at risk for dry eye? Well, those who are taking certain medications can cause dry eye, such as blood pressure control or birth control pills. So these type of medications can cause dry eye. Or if a patient have undergone refractive surgery like LASIK, that can trigger the dry eye condition. And a certain working environment, as mentioned, if you're working in a smoking area or the increase of aircon or improper positions of the computer displays can also cause dry eye. And also certain immune system disorder like systemic lupus, erythematous, rheumatoid arthritis, these autoimmune condition. Actually, one symptom is with these conditions is dry eye. And certain eye structural defects, like as in some elderly patients, maybe you have conditions of eyelids not holding in place properly, things like that. And also sometimes contact lens wear can trigger dry eye. And aging also, aging is also one factor for dry eyes, because then it affects your the production of tears maybe, or the tear component is not correct. And so what are the symptoms of dry eyes? Well, the eyes feel dry, or more than that, the eyes may feel very irritated, uncomfortable. There may be stinging or burning sensation, or the patients may feel their eyes, there is a feeling of sandy and grittiness. The heavy eyelids, maybe patients feel like they want to close their eyes all the time. That is quite a common complaint too. And redness, eye redness, their eyes always look red. And in severe cases, maybe the patient experience blurry vision. And here, yeah, you may find it contradictory that it's for dry eye symptoms, how come the patients will feel watery eyes? Well, that is two mechanisms of producing tears. This happens like a protective mechanism, that the eyes do not produce enough tears or proper components of the tears, and it's like a protective mechanism that influx of or increase in or uncontrollable increase in tears to wet the eyes because of extreme uncomfortable in the eye. So that can cause watery eyes as well. So if a patient complains about uncomfortable eyes and the eyes will have sudden tearing, and that can actually be induced by dry eyes. And one way of investigating whether the patient has dry eye is by the use of slit lamp and a special type of color for the eye called fluorescein. So with the use of slit lamp, you can look through the eyepiece, and with the enlarged image of the eye, and after installation of this special eye coloring, which is yellow in color, what happened is that it mixed with the tears, and then with use of blue light, you can see that the surface of the eyes with tears will become green, and you can see these dry spots developing if the patient has a low level of tears and or tear breakup time. That means you can see when once they blink, it should bring the tears all over their eyes, and then you wait for the patients to hold the blink and to see when these dry spots develop. And how are dry eyes treated? Well, very commonly is the use of artificial tears, that is lubrication that you put in the eye, or natural supplements, vitamins that can also help, because antioxidants can help the overall health of the eye, and see if that helps with the productions of tears. Changing environmental factors like turning the aircon off, or to less windy mode, or making the environment more humid. Lid hygiene is also one factor. And also warm compress sometimes help, because it's help increase the circulations around the glands that help produce the tears. And then there is also something called punctal plug. That's just to show you, these are plugs that slow down the outflow.
Tears drain out of the eye through a tiny opening of the tear ducts on the eyelid margin, called puncta, then through a small channel into the nose. This is why your nose runs when you cry. Your ophthalmologist may recommend closing off the puncta, either temporarily or permanently, using tiny punctal plugs. Punctal plugs can be inserted in the lower eyelid, the upper eyelid, or in both eyelids. Using punctal plugs saves your own tears from draining away and helps artificial tears last longer.
Okay, just showing you this because I think this is like a little bit more interesting, and to let you know that there is such a thing to help with the dry eye treatment. Okay, so eye drops as mentioned, but not all type of eye drops, because each are of different components and for different conditions. Like there are some for allergy, so you really have to look at the ingredients and see what they are for. The best will be those without preservative, and for artificial tears or lubricants for the eye, and with less, not with those with medications that is for eye allergy or eye redness and things like that. So be careful with what the ingredients are. Okay, this is just to show you sometimes in severe cases, dry eye cases, if the tears condition is very poor, that can obscure your vision like this. Okay, so you need, then the patients of severe dry eye may need constant blinking, and that can be very disabling to their daily life as well. Okay, so that concludes what we want to talk about on common eye disease. Is there any questions on the first part of our lecture? Okay, if there's no question, then let's have a 5 minutes toilet break, and then we come back for our second lecture on community needs and vision screening. So, okay, let's make it a very quick break. All right, so let's continue with the second part of the lecture. So for this one, we change the topic totally. We're going to talk about the actual needs or the actual planning, what you need to take into consideration when you're planning for a community needs and when you actually do your planning for the vision screening. Well, if you recall, the intended learning outcomes or the objectives of this subject, one of them is to understand the major eye-related health issues or concerns and their impact upon the underprivileged in the community. And second is to plan, organize, and conduct vision screening projects in collaboration with community organizations. Well, so hopefully after this lecture, you at least understand some of the major health eye-related concerns, that you understand about the some common eye diseases and how they impact in the community. And also this part where we will look into how you should think about planning and organize and conducting your vision screening, which you'll be doing it soon, I suppose, in future weeks or months. And when we look at conducting a screening, we have to look into why are we doing this? These are the basic questions that we want to ask ourselves. Why, who, where, when, what, and how. When you are clear about answers to these questions, then it will become clear to you what to be included and how you should and what you should do in planning for your vision screening. So hopefully by the end of this lecture, and it helps you when you think about designing your vision screening project. And these are some pictures that are the tests that may be performed in the past in a vision screening event. Okay, so give you some hints on what to be included. While looking back at the full picture, so screening in a general definitions, why are we doing screening and not doing comprehensive tests, for example, for the population? Well, we do screening because we want to do a systematic search in the population. And so we want to pick out those defective ones from normal. Defective, not about the person, but the defective of the conditions or eye health, etc. So we want to look into the population who are unaware themselves that they have a certain problem, and we want to pick those high-risk conditions out so that is doing some help to the community. And we want to pick out the deviations from the norms. For example, IOP is one example, refractive error is another thing. So deviations from the norms, for example, we have to set a criteria. And for example, this is any eye pressure higher than 21, which is at a greater risk of developing glaucoma. So we pick that as a criteria. And then that means those that we picked out would be the ones that are at a greater risk of developing glaucoma. Or visions who are worse than 6/9 or 6/12. Those may be the kids who are at risk of having short-sightedness, that they need glasses. So we want to pick out these deviations from the norms, from the populations that we're looking into. So there are two objectives of screening. One is prescriptive and the other one is investigative. Prescriptive is good for the subject, it's good for the participants. What we do is we identify those individuals with a suspected condition that may require further evaluation or treatment. So that is very personal. That person can actually benefit from the screening, from your screening, because you can then offer advice, referral, or tentative diagnosis so they know that they have the problem. Whereas even for those who don't have the problems, then that is with among the normal populations, then they have a sense of security, then they feel safe. Okay, so I've done this, and at least I've done some basic tests, then I know that my eyes are good. So that is prescriptive, more personal and beneficial to individual participants. And the second objective for screening is investigative. So you gather information on the prevalence or incidence pretty much like an epidemiological study. So that is good for the whole population. You gain information not for each individual, but as a whole. So with that information at hand, what can be done is maybe you present this data or information to the government so they know where to allocate resources. Or, for example, if there's an epidemiological study that says the prevalence of short-sightedness is really high, starting from K3, children in kindergarten. And so the government may need to allocate more resources to do tests or educations or whatever to children at a younger age compared to now. So, which yearly departmental health screening provided by the government starts from P1. Okay, so it helps for improving government policies. And also, on the other hand, is that it may increase awareness from the populations that using the short-sightedness example in kindergarten, maybe then parents will learn about that and becomes more aware and help lifestyle modification for younger kids, and that will be more beneficial for the younger generations, etc. Okay, so as mentioned, the primary objectives prescriptive that is beneficial to individuals, and investigative that is beneficial to the community as a whole. And well, that answered the question kind of why do we perform screening that's in a broader term. But I also want to sort of introduce our role as optometrists. Well, I haven't introduced myself actually. I'm an optometrist in private practice, and so you understand that this subject is organized by the School of Optometry. So are you familiar with optometrists or optometry? Maybe or maybe not. Well, we are primary healthcare professionals to provide eye care services. What we mean by primary healthcare is we are the first point of contact when you realize there is a vision problem or eye problem. We are the person that you first think of. So we are we can examine, diagnose, treat, and manage diseases and disorders of the visual system. So that's our role in visions. Okay, and this is not the most updated list, but it's quite current anyway. So you may notice that there are, in our registration system, we have 4 parts of registrants, part 1, 2, 3, and 4. And as you look into this list here, this is from our optometry board of optometry. And so we are all bound by this. You can see that there are different restrictions on practice. The one without restrictions are part 1 optometrists that are university graduates. The development of the optometry in Hong Kong is quite similar to Chinese medical doctor, for example. So in the past, when there were no proper education for optometrists, a lot of the optometrists gain their experience and their knowledge from apprenticeship. So they work in the profession and start to learn from their work environment. So there's no formal education for optometry on its own. And of course, as the society advances, all these different specialty or healthcare becomes more advanced on their development on their own. So what happened is with the beginning of the course for certificate of optometry started in the Polytechnic then, that happens in 1980s. And as the program continued to develop and progress, and it now becomes a bachelor degree, and we have doctor's degree, master's and doctor's degree, etc. So that's why we have all 4 parts of registrants. That is from historical reason, where part 4 optometrists are the sort of grandfathers in the business, where they gain experience from their workplace, whereas part 1 are university graduates. Now they have to be bachelor degree, and for you to register in the optometry registrations, you have to have a degree in optometry. So that's how the same as many other professions, that's how our profession changed over the years. Okay, so just give you some idea of the registration come into place, and how we develop to what we are now. Okay, so back to the concepts for vision screening. There are some principles or factors for considerations when you design your vision screening protocols. And when we look at what sort of eye diseases we should keep in mind when we are designing when we are designing your vision screening event. Well, there are many ocular conditions are treatable if discovered early. So we have to think about what are the needs for that population. So these are some of the eye diseases that I'm just throwing out at you. But after considering different principles, I want you to look back at the list and see what is more important, what you should include in your vision screening project. So if we look into these primary open-angle glaucoma, remember primary open-angle glaucoma, remember what it is that we've just talked about. That is the silent thief of sight. So the patient don't experience any symptoms in the beginning. Keratitis, do you know what it is? It means inflammation of the cornea. So that usually involves pain, or maybe blurring of vision, uncomfortable, or a discharge from the eye, things like that. Acute angle closure glaucoma. That is, we have talked about this just now, also in the first part of the lecture. That will be very noticeable by the patient, him or herself. Painful, blurry vision, and nauseating headaches, a red eye. Diabetic retinopathy, we've just talked about this as well. Strabismus, that means eye squint. Refractive errors, well, maybe short-sightedness, long-sightedness, and astigmatism. You've learned that in your first lecture. And lazy eye. Don't know if you come across this in your first lecture. I suppose so. Okay, so these are things to think about first of these conditions. And then let's look at what we have to consider when we are thinking about what to include for our vision screening project. Well, we look into 3 factors. Whether that eye disease is, whether that is a concern, whether we want to establish that as a need, is whether that is asymptomatic in nature. So are there obvious symptoms, or is it asymptomatic? And how common it is within the population, and how treatable it is. So let's look at this one by one. If it is not painful and itchy, or is there any redness, if the progression is gradual, if it is sudden, then the patient will know, it will be more noticeable for the patient. But if this is gradual, slow progression, then the patient may not notice about the change. And if there is sufficient residual functions, like if the patients can still see fairly well, or like glaucoma, if it is the side vision that is gone, then the patient won't notice it until a very late stage. Or does it affect both eyes together, or does it affect just one eye only? And whether that is happening early in childhood. These are the characters that may go unnoticed. So if early onset in childhood, because children usually don't know how to complain about their vision problems because they have nothing to compare with. Whereas for adults, if there is a drop in vision, then they can tell. Okay, so these are the things that may go more easily unnoticed. Whereas if the eye disease have noticeable symptoms, if it gives rise to noticeable symptoms, or manifested symptoms, so these conditions will be more self-referring. And for self-referring characteristics eye diseases, the educational program will be more effective, right? Because then they will notice themselves, and they may refer themselves and seek for help on their own, instead of that they need to wait and go through a vision screening project. Okay? So with this in mind, let's look back at our list of eye disease, whether establishing the needs. With primary open-angle glaucoma, do you think it fits in this? It's asymptomatic. Do you think you should include tests for ruling out glaucoma or picking up if the patients have got glaucoma? I would say yes, because that is definitely an asymptomatic condition, right? Patients will easily go unnoticed. So if you can pick up the conditions through a vision screening program, that will be beneficial for the patients and to the society as a whole as well. What about keratitis? Is that asymptomatic? It's not, because the patients will usually experience pain in the eye. And as mentioned, this type of condition, keratitis, that is the second condition here, inflammation of the cornea. With this, patients will experience problem and will seek for help themselves. Okay. And for the third condition, acute angle closure glaucoma, do you think it is good to include it in vision screening, or there's no need? No need, right? Very good, because it is so noticeable by the patients. And diabetic retinopathy, well, we'll talk about this later, because then it also involved the prevalence, the second point of prevalence. The percentage of the cases of disease in the population at a specific time. So is it significant in the number of total cases, and also whether that is cost effective? What is the impact to the community? If it is, for example, dry eye problem is less impact to the community, and probably is also very noticeable by the patients themselves. They will seek for their own help, and it's probably not worth, and it's not necessary to include that into your vision screening event. Okay, with prevalence, let's look into our fourth condition, diabetic retinopathy. So it will fit into our prevalence point if we are looking into a society, for example, with diabetes, right? In the general population, well, it depends. It depends. If your target audience or the target of your screening targets are school-age children, would you include diabetic retinopathy? You won't, because the percentage of school-age children having diabetes are low, right? But how about elderly patients? Yes, maybe in a nursing home, you will want to include diabetic retinopathy. Or even more, if you are providing vision screening for the society, Hong Kong Society of Diabetes Mellitus, of course, then definitely you want to include that into your vision screening protocol, right? Because that will be very prevalent in your the population that you are serving. Okay, so that makes sense, right? Okay, what about strabismus? Yes or no? Because strabismus, that means eye squint. So for school-age children, it's important, but for adults, maybe it is less important. Refractive errors, again, it is important for school-aged, young children, young patients, but probably, well, also for elderly patients too, because they may need reading glasses, they may not be able to afford it, etc. Amblyopia, lazy eye, that usually have an early onset. That goes into our point of asymptomatic, because it's early onset and the patient may not notice it. And however, also have to take note of our second point, the prevalence and then the impact to the community. So do you think it is necessary to take into considerations for lazy eye if you are designing vision screening for school-age children? Yes, because you want to pick out those with lazy eye because they won't be able to tell on their own for children. But do you want to take that into consideration for an elderly population? Probably not, because it won't have much impact to them that they have lived with their lazy eye for so long. And then that also leads to our third point, whether that is treatable. So in elderly patients with lazy eye, they probably don't bother treating, because in treating lazy eye, it involves patching eye and all that, more like exercise rather than medication or surgery. So for elderly patients, probably not worth treating if they have the lazy eye since childhood. Okay, so that is also the last point for establishment of needs for the vision screening, is that do you look into conditions that are treatable, and how available and how affordable are the treatments? But I can think of an exception for this. What about color vision? Color vision for children. You may argue that color vision is not treatable, so do you think it is required in the vision screening protocol? I would say yes, even if it is not treatable, but think about education or advice for the patients for their career counseling, maybe for them to choose their future career path. And also maybe able to identify colors is important in the school. So picking out those who are color deficient should be necessary for children to let their educators know about that, right? So that is one exception that, oh, you may argue that although it is not treatable, but you still want to include that into your vision screening project because of blah, blah, blah reasons, okay? All right, so let's have a look at visual impairments and blindness in the world, so we know how these vision conditions are impacting the whole human population. Well, the world population is around that is from 2012, so it's probably quite different now with all these COVID conditions, and then there's change in the population. But anyway, looking at the numbers then, We have 6,690, well, around 6,000 million people, and 4.25% actually have visual impairments. That is a drop in visual functions. And among those, 14% of those with low vision is actually blind. So you have quite a number of people who have poor vision. And if we look into the visual impairment, we can see that cataract and uncorrected refractive errors contribute to the biggest percentage of avoidable visual impairments. Because we understand that with uncorrected refractive error, you see very poorly without glasses, maybe third world countries who can't afford a pair of glasses. But with that, you may actually improve 42% of the population with better vision. So that's actually quite devastated to see that there are so many people in the world who suffered from poor vision, but can actually fix with just a pair of glasses. And then cataract, of course, these will require more sophisticated treatment, that is cataract surgery. And if we look into avoidable blindness, you will see that cataract is also one big eye diseases that are the leading causes of avoidable blindness, and the other 8% are glaucoma. Okay, so these are definitely avoidable blindness, but again, due to lack of resources, lack of medication or treatment, and it leads to blindness in this population. And as we can see here, prevalence of people of all ages with visual impairment, that is also in the year 2012, 10, 12. So those with the biggest amount of percentage with visual impairments are East Africa and Middle East and China, and then also Asia. So these are the area that have the biggest amount of visual impairment. So we understand now that the needs in not just Hong Kong but the world are great for proper visual healthcare, visual care. And yeah, so whom are you going to serve? People with difficulties accessing vision and eye health care services, but that may include elderly people in nursing home. Maybe they are not free to go to seek for their eye services, or school children, underprivileged people, new immigrants, low-income families, refugees, or ethnic minorities, as well as those that are afflicted with physical and mental disabilities. So those who have difficulties accessing vision care, usually underprivileged population. Okay, but before we get into what we can do, let's take a look at what the government is doing now. So as you can see here, for children, they actually offer vision screening, but the screening is quite simple. As you can see here, it only involves 3 tests: visual acuity test, stereopsis test, and color vision. And these 3 tests are not performed yearly, but the visual acuity is performed from primary 1 and then every year up to secondary 6, which is quite good. So that is for picking up if they need glasses. And however, the stereopsis tests are only performed in primary 1. Although you may argue that, okay, their conditions may have binocular vision, conditions may be quite stable or whatever, but this is definitely not enough because it's just a screening. So what if they missed some? And there's no way of picking it up the second year or third year because they're only doing it once. And color vision test, I don't understand why they delayed it until performing it at primary 6, because then that means if a patient has, or if a kid has color vision problems, they may go unnoticed for the whole 6 years in their primary life. Then they may be wondering why they are always picking the wrong color in art classes or other classes and not knowing that they have color vision. So I think that is not a very good plan in providing these services. But anyway, that is how the health program is for the moment. And have you heard about healthcare vouchers? That is available for elderly patients aged 65 and above. They have 2,000 years per year, but unfortunately for optometrists, for our vision health services, elderly patients can only obtain $2,000 for vision care every 2 years. So that is some restrictions for what they can get from us. But anyway, that's how the government works, and that's it. So you may say that they are being taken care of in terms of eye health or eye care, but in the end, it is not necessarily like that, because these money are for all these healthcare providers. So it really depends if an elderly patient who miss the need for healthcare, they may be spending all their money for other things and not taking note that they may also need checking for their eye health, for their eye care. So I don't think that is a true justification for providing, like we may not be we may not be able to provide the service even though they have the money. That's what I'm trying to say. Okay. So let's take a look at these different cases and see the need for health check, see the importance of health check. So this is a type 2 diabetic patients that have diabetes for quite some years. And if you do some very trivial checking of refraction and just checking the vision, you may find that, okay, they're fine. But when you look into their retina, that may be what you're looking at. And of course, that means the patient have diabetic retinopathy and referral is required. They may need to have the doctors look into the level of blood sugar and see if they have properly controlled their blood sugar level, and also look into the eye health and if they need a treatment for that. And for amblyopia, 3-year-old routine eye check, and they look on the outlook may be fine, and parents may not notice anything, but in the end, they have this patient has a high longsightedness in one eye and also some eye turn. So this may go unnoticed if the parents are not very familiar with how the eye should look like and things like that. And this is also another case. There may be some blurry vision, but it's not too bad. And then looking at the back seems fine, but with a dilated pupil, you can see that it's actually this part is detached. So you can see that the tissue looks different from the top, right? It's all wrinkled up. That's because the this part of the retina is actually detached. So these type of patients will it will be requiring a proper eye check, actually. And just to let you know that the code of practice for us, for optometrists, there should not be announcement on discount or free professional services. Otherwise, we are breaching our code of practice. So that's also one important point for you when you design or your information sheet to the institute or your target subject or your target audience for your screening. You never put in a free eye examinations, because then we as optometrists will be in breach of our code of practice. But we can say that it is a free screening. But it's important for you to properly explain that screening doesn't equals to a full eye examination. So that's you have to be very careful with your wordings when you are designing for the information sheet, etc., or when you are actually explaining what you're going to do with the institution. Okay, and design of the screening protocols. Well, we have to take into these considerations. First, it has to be innocuous, that is, doing no harm. You cannot harm the patients while you're doing the screening, right? So do no harm. So best if it is painless. Maybe some tests you have to have mild discomfort, but try to choose those that are most comfortable. And non-invasive, so there is no physical damages to the patient. And even eye drops, sometimes you think that is more invasive, and so we try not to do tests that may involve instilling eye drops and things like that for the patient. And secondly, it has to be of little difficulty, because some of you are, well, you are not an optometry student, so you may not be familiar with some of the eye tests that involved. And so, and then you may get other helper as well. And so the tests that you use may be best to be those that are easy to perform, and also fast to perform and easy to learn. So like not very difficult and complicated in use. And also best to use inexpensive tests, because that would be cost effectiveness we have to take into considerations. And inexpensive tests, and also tests that can be easy to do and that can increase the number of participants in your screening. Okay, so that are the three main points when you design for your screening protocols. Do no harm, with little difficulty, and inexpensive. Okay. And before you get into performing the screening, you have to provide information. Well, I believe you will have a chance to talk to the institutions and establish their needs, see what the populations are at risk of, what type of populations that you will be serving. And so, and then think about how to put into the information what they need. Is it given to the individuals being screened, to the participants? If they are school children, then do you give them to the teachers or school administrators, or to the parents, to the caretakers? Things like that. So before you actually get onto the screening itself, you have to think about this. And also in the communications with the other parties, you have to explain the limitations and implications of screening. So as explained, you don't say that it can replace a full eye check, because it can never do that. Rather, you explain that it is not a full eye check, but it's a screening test, and it is not as comprehensive. But what you have done is blah, 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 and if they need further investigation or whatever. And also, you have to establish a follow-up system or a referral system. So if they need further investigation, what to do? Do you have a list of referral, or do you have plans for them to do a second test, or come back to PolyU for further investigations and things like that? All right. Okay, so back to some theory. In thinking about protocols for screening, there are two major difference. One is monophasic, that means you are targeting one disorder. And then the other one is multiphasic screening, that means you are doing on one person, but you are targeting more than one disorder. So if you are targeting one disorder, for example, you are applying one or more tests to identify a single disorder. So tests can be arranged in series or parallel. So in series, that means if a patient fails test 1, then you go on to test 2 and 3. And if they fail all tests, then they fail the screening. But in parallel, that means they have 1, 2, 3, 4, 10, or 1, 2, 3 tests unrelated to each other. If they failed any one, they fail the screening. Okay. One example of monophasic screening can be you are providing the service to Hong Kong Association of Diabetes Mellitus. So you are just targeting diabetic retinopathy, for example. Okay, but most likely your protocols will be the multiphasic screening, that for a certain population you are targeting more than one disorder, maybe general, just ocular health. So if you are doing, you are performing a screening for a nursing home of elderly population, then you want to screen out all those with cataract, with glaucoma, with diabetic retinopathy, hypertensive retinopathy, and ARMD, blah, blah, blah. Okay? So that would be multiphasic, and most of you will be performing, will be looking into multiphasic screening, I think. So the advantage of multiphasic screening would be is efficient, because you're doing all tests and then picking out different disorders that may occur. And so you get more data, and it's more cost effective, because then you are picking out more conditions, and also larger impacts to more concerns from the patient's point of view. Okay. And the disadvantage would be because it increases the difficulties in designing your protocol. You'll be doing IOP tests, and then you're doing AMSA chart, for example, and then you're taking many different tests. So it increases the difficulties or complexity. And then also it will be more difficult to interpret the results, and also time and resources are more consuming. You need to bring in a lot of different equipment and tests, and also to the public, maybe they get confused more easily, that they're doing 10 tests and they don't understand what that test involved, and they have to go through different stations and things like that. And this is an example of a vision screening report. So I just want to emphasize this again, that you have to explain properly to the participants involved, and then also the institution, that this is not a complete professional examination. Okay, this is a screening procedure. Okay. Well, now we are looking into how or a more statistics form of evaluating your vision screening, and what do you mean by a successful screening? Well, there are 3 points: reliability, validity, and yield. So reliability, how reliable is your measurement? Of course, for a measurements to be reliable, first of all, it has to be repeatable. That is, under the same circumstances, on the same person, you have the same result. If it is not repeatable, you have one result on one day, on 1 second, and other results on the second result under same condition on the same person, that is not repeatable, and that means your test is not reliable. And validity, how true is your result? And so how do you identify those types of conditions, and how confident you are that you are giving the true results? That's how valid is your result. And yield is the number of newly identified cases. Well, you have to have the 2 points. That's a reliable test, a valid test, and then the yield will give you important information. Otherwise, the yield is no use. Okay. And so to try to sort of strengthen and enhance what the wordings and this concept means, the measure of repeatability, instrument A and B, under same conditions, and on the same individual, you give same results. And which instrument is more repeatable, A or B? A. you should have more confidence in raising your hands. Okay, instrument A is more repeatable because you can see that the numbers are all the same, whereas for B, it can range from 19 and 11. That's a big range. Okay, so instrument A is more repeatable and more reliable. So all the tests that we try to use should have a proven high reliability. But also, of course, the test can be reliable, but the results can still be affected by how we set up in the environment. Because instead of a proper clinic, we are maybe doing it outdoors or etc. So these are the limitations that we have. Maybe we don't have the proper electricity to light up, etc. So different lighting levels, etc. So we try to take that into consideration. Use tests that are required or that are less affected by the environment. For example, if they have a self-lighting system or whatever, for example. And the test procedures, if it is a complicated test, maybe the test procedures are less easy to keep it repeatable. And of course, subjects' attention and cooperation is required. We all understand, for example, if you are performing the test on younger children, they may not be cooperative, etc. And then your test may not be as reliable as you perform it on an adult patient. And also examiner, so that is your responsibility to be familiar with the test that you're using, because your experience, your knowledge, and then how alert you are with the patient's response also affect how reliable the test is. And of course, that may that there will be human errors that we can't avoid. Okay. And validity, a measure of agreement between a test and the standard. With all these tests, we have a standard test. We know that will be the golden test, golden standard test, but we may not be able to use the golden test because the golden standard test may not be portable, for example, and we cannot offer it to the vision screening venue. But no matter what, we have to try to find the best agreement between a standard test and the equipment that we're using, for example. So validity offers a measure of the accuracy of the results to the accepted standards. But of course, we have we have our technicians, helpers to calibrate the test and make sure that that is within an acceptable standard. And good reliability is an indicator that the test will be valid. If the test is not repeatable, not reliable, then let alone its validity. Okay, so just a quick questions again. If the standard test yield results of 18, 18, and 17, which instrument is the most valid one? A, B, how about instrument C? Yes, instrument C is the ones that agree most with the standard test. So it is the most valid test. Okay, and last but not least, this information here of validity is the ability to identify those who have the conditions. Okay, this is another concept that I try to introduce to you, and hopefully you remember when we look into the outcomes and how we design the criteria, pass-fail criteria can affect how successful our screening is. So getting into the results of a screening, when we put in this information, when we look down, when we look into these columns, these tables, when we look down, these are the patients with the disorder. If we look down the column, we can see that the patient has the disorder, they should fail screening. Okay, so this is a true positive. But if we made mistakes or there are human errors or whatever, that they actually have the disorder but pass screening, that becomes a false positive, right? And if we move across this table for the normal patients, the best result will be they should pass the screening, right? So that these are the true negative. because they are normal patients and they should pass it. But again, with whatever errors that is during the test, if they fail screening, these are false positive. So in the ideal world, in a perfect world, we want to keep B and C, this positive and negative, to 0, right? If these are 0, that means all the numbers we found will be the true results. That is, those that fail screening are the one that has the disorder. Those that pass the screening are normal patients, right? That would be the most ideal world. But unfortunately, we don't live in an ideal world, so there will be false positive and false negative. So what's wrong with having false positive and false negative? Well, false negative, it gives the patients false sense of security. So you're telling them, oh, your results are all good, you are fine, you can go home safely. And then but then in fact they have the disorder, so that delay further investigation and treatment. Remember, what we're trying to do with screening is to detect early and treat early, so to keep the damage to the minimum, right? So that forfeit the benefit of screening. Okay, but if you are making the passing criteria too stringent and you are failing everyone who are normal, then what happens? You have a lot of false positive. Then you are referring unnecessarily. And you are also scaring the patients. Well, they don't have the conditions, but you're saying, oh, this is very suspicious. You're likely to get blah, 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 and you better go see the most expensive doctor in the city. Right, so you are wasting money, wasting the time, and also scaring them off. Okay, so these are we're trying to keep false negative and false positive to the minimum. That's the goal for the best screening result. Okay, and I also want to introduce this concept of sensitivity and specificity. But if you look into the description, it will confuse you very much. Sensitivity is the accuracy of the screening to correctly identify all individuals who have the particular disorder. So it is A, if you have the table, look at the table there. A on A plus C times 100, so that's a percentage of how sensitive the test is. And for specificity, is the normal patient, so D on B plus D. Okay, so this is the sensitivity is the accuracy that you screen out the abnormal one. But the specificity is the opposite, that you have screened properly, that the patients, you have screened the normal one, they are normal. Okay, that's the specificity. Okay, so one is that you pick out the disorder correctly. The other one is you correctly identify the normal. Okay, and it may find it confusing with positive and negative predictivity, because that is how you predict the results, whether your prediction is correct and incorrect or incorrect. And positive is that you identify the disorder one properly, and the negative one is to predict the normal one correctly. These concepts, when you first look at them, seems confusing, but the important point is you look at the denominator. This is called the denominator, right? The denominator here. So let's go back to the table here. So with the denominator of sensitivity, you are looking at the person who has actually disorder, right? So your denominator is A plus C. And those who fail screening are the ones that you identify and that actually failed the screening. So that's A on A plus C. Specificity, which is related to sensitivity, you are looking at B plus D. That means the denominator is the actual person who has the disorder or the actual person who are normal, the actual population of with disorder or the actual normal population. Okay? But with positive and negative predictive value, your denominator, you're looking at it at the column, at a row. So the denominator is for all those that have failed screening. Okay, so the denominator is your results. How many of the one that you say that they have failed screening are actually have the disorder? Okay, that is the positive predictive value, and negative is the other way around. So those you say, these are the results of your past screening. So you pass them all. How many of those are actually normal? Okay, so when you look into the mathematics formula and you look at the denominator, you can kind of tell they are of different concepts. Okay, that may take time to digest. But in order to tell you why we have to look at it in these 4 different concepts, or these 2 big categories, the concept into looking at the real population versus looking at your screening predictive value, let's have a look at the tape. I try to make it easier by putting it into a figure form. So as you can see here, this is in the orange, the green populations are the normal ones. And the blue population, the blue box is the subject with disorder. That is the true value, okay? But you have only identified the orange box as the one with disorder. So you actually missed out 50% of the one with disorder. Okay, but what happened if we look at the sensitivity of this test? This is very low because you're only identifying 50% of the population, right, of the disorder population, so only 50%. But what about positive predictive value? Positive predictive value, that means out of all those you identify with the disorder, how many percent truly have the disorder? Out of the orange box, how many is actually blue in color? So it's actually 100%, right? Because you are saying, okay, these ones are the ones that identified with the disorder, and you're actually doing very well if you're just looking at one value, right? It seems to tell you, whoa, you're doing good, you're predicting 100%, right? But actually sensitivity is only 50%, okay? And what about specificity? If you are talking about those in the green colored, this area, this is the true normal value. And what about the percentage that you say is normal? It's actually this one, the non-dotted box, right? So specificity in your case will also be 100%, right? Because of those subjects that are normal, you are also saying that, oh yeah, these are all normal, right? So this is also 100% of the green one that you identify as normal. So again, if you only look at specificity, you will think, oh, you're doing a pretty good job too. But with the negative predictive value is different, because with the negative predictive, you are predicting this with the blue box here. So this is the area that you are predictive negative value. So the whole area minus the orange box. But among those, this area, only the green colored area is the one that is truly normal. And quickly, that will be 6 out of 7 portions. That is an 85%. So think about that. You can just write it down. You can just write down the value 100%, 100%, and this is 85%, 6 out of 7. So do that at home if you find it confusing now. Just to show you that you have to look at these 4 different values to identify whether your screening is successful or not. You can't just look into just one value, okay? Because if you just pick one and look, you may get a really good result, but in actual fact, you are not doing such a good job, okay? And in reality, you will, of course, this is just an extreme case. In reality, you are most likely identifying something like this in the orange dotted line there. That means you will have some unidentified normal case, and you will have some false positive. Keep it things simple. You have some false positive, and some negative results. Okay, and just the last slide. How much time do I have? Okay, I think we're pretty much on time. Last one here. These, of course, are just make up value. I don't want to get into each of the calculations there, but you can see here. This is just an example to show you. If you set up a reasonable pass-fail criteria, you should get a pretty good result. This will be a successful screening, that you have a good outcome. But if you make this criteria too easy to pass, this is the vision acuity test. Remember how the notation is from your first lecture. So this is like, even if you can't see the big letters up on the chart, you can still pass. This is an easy pass criteria for your vision. Then you may be missing out a lot with those who have the refractive error, and in messing up with the pass-fail criteria and passing all these, you should not pass. You will get a low sensitivity, and then your negative predictivity value will also be reduced. But then you may get, so this is same as the example with the figure that I just showed you. That's a low sensitivity, but your specificity on positive predictive value may seem to be quite good. Okay, so just an example to show you. That's why you have to think about what pass-fail criteria to set in order to give you good results for your vision screening. Okay, so hopefully this last section of this kind of statistics concept won't confuse you too much. But if you do, you just need to look again, as I mentioned, at the denominator of the table and think it through. I think you should be able to grasp the concept. Okay, is there any question? If not, then let's call it the day. And yeah, happy Mid-Autumn Festival. Okay, yeah.